Uh, Hope I'm audible. Good afternoon, everybody. I'm Dr. Rajan. Today, we'll be talking about the diagnosis, course, and management of hypersensitive pneumonitis. Our goal in this lecture is to move beyond the traditional definition and look at the modern multidisciplinary approach to this complex immune-mediated ILD. So, the most critical takeaway from today is there is a paradigm shift in the understanding of hypersensitive pneumonitis. We have moved away from the obsolete time-based model that we used to initially study, the acute, subacute, and the chronic hypersensitive pneumonitis, because it failed to predict the outcomes accurately. Instead, now we have moved on to the structural based model where the fibrosis dictates the survival. So we now categorize hypersensitive pneumonitis, HP, as non-fibrotic HP, which is potentially reversible and it is purely inflammatory, or we divide it into fibrotic HP, which is irreversible and often mirrors IPF. So we also now recognize a term called as cryptogenic HP, where it is the features are of typical HP, but there is no identifiable antigen exposure present. So now we have moved on from the time-based model of acute, subacute, and chronic HP to more a structural-based model that is non-fibrotic and fibrotic HP. So what is the pathogenic equation and the inflammatory uh, cascade? So HP is a result of a susceptible host meeting an environmental antigen. So on the host side, we look for genetic markers such as MUC5B allele, which is linked to the radiographic fibrosis, or short telomeres, which correlate with worse survival. So when these sort of hosts meet with the environmental agent, so environmental agent is, it could be a microbial, avian, plant, chemical haptens, etc. A lot of environmental exposure haptens are present. So when these susceptible hosts meets the environmental antigen, so they can either enter into an inflammatory pathway through the T helper cells, IgG, which leads to lymphocytic accumulation and granulomas, and these cause the non-fibrotic HP, or if there is recurrent epithelial injury, fibroblast activation, and extracellular matrix excision, they can lead into the fibrotic HP pathway. So diagnostic funnel converging at the is, so now there's a diagnostic funnel available. In this, so you have to look at the exposure history, you have to look at the imaging, HRCT imaging, and in some cases, BAL and biopsy, which I'll come to in the later stages of the lecture. And after all these, we have to go through a multidisciplinary discussion to diagnose HP, because HP features often overlap with other ILDs. And it is very important to have a multidisciplinary discussion to actually confirm the diagnosis. So first step is the exposure search. So first we have to identify the inciting antigen, and if you have identified the inciting antigen, they say it is linked to an improved survivor. So, however, there are very significant clinical limitations because there is no single questionnaire, or IgG testing can only tell about sensitization, not active disease. So, there are a lot of clinical challenges available to identify the inciting antigen. So, what are the typical sources? At home, there could be mold, there could be birds. At workplace, there could be chemicals, other haptens. In environment can be recreational environment as well. So the structured questionnaire, specific IgG testing, and specific inhalational challenge tests are available. However, there is no one single questionnaire or a universal tool which exists as of now, which you can ask to, which is present, so you can assess the antigen exposure. Again, IgG testing is available, but however, it cannot distinguish between the active disease and mere sensitization from the inciting antigen. There is something called as specific inhalation challenge. However, it is highly sensitive specific, but it is restricted as of now to very highly expert centers. So the step 2 in the diagnosis is HRCT imaging, mapping the airway centered inflammation. So in non-fibrotic HP, we look for airway centered inflammation. Key markers include centrilobular ground glass nodules, lobular air trapping, which is visible more so on an expiratory scan, and patchy ground glass opacities, often referred to as mosaic attenuation. So, in
हाँ
non-fibrotic,
पागल पेशेंट, हाँ दिमाग खा गया। उसको एडमिट होने की नहीं होना, वो इतना डिसीजन नहीं ले पा रही है, बस कंप्लेंट्स बोले जा रही है, बस बोल के
I
ही
would
रहेगी
request you
कंप्लेंट्स।
to
मैं
kindly
बोल रही हूँ
unmute
तो
your
एडमिट हो।
kindly mute yourself and do not. Uh, yeah, so kindly do not unmute the session. Uh, so again, talking about the HRCT imaging. So in non-fibrotic HP, we look for the airway-centered inflammation, that is bronchulocentric inflammation, generally as ill-defined centrilobular ground glass nodules. Then we look for lobular air trapping, which is more prominent in the expiratory films, and patchy ground glass opacity, mosaic attenuations. Then there's something called as the classical three density pattern. The most specific sign of HP on a CT scan is something called as a three density pattern. Formerly, it was called as the head cheese sign. It is characterized by three distinct lung zones. So one is the normal lung, which you can see on the left side of the image, which is a mid-gray normal lung parenchyma. Then you have the inflammation, that is the lighter, denser ground glass, which you can see on the right side. And third is the air trapping, that is darker, lower density lobules with reduced vessel size. So air trapping. So this is the classical sign seen in HP, the three density pattern sign, formerly called as the head chin sign, and it is most specific for HP on HRCT, and this is highly accentuated on the expiratory scans. Now, HRCT in the fibrotic HP. So we talked about HRCT on the uh, non-fibrotic HP. Now talking about HRCT findings on fibrotic HP. So when HP transitions to the fibrotic tract, we see irreversible damage to the lung. So we see reticular abnormalities, we see traction bronchiectasis, and we see honeycombing. So three things, if the HP has taken the fibrotic pathway, we will see reticular opacities, we will see traction bronchiectasis, and we will see honeycombing. If you can see, so this is the honeycombing. Traction bronchiectasis is a tram track appearance, loss of volume along with it. And differentiating fibrotic HP from IPF is very difficult. And however, fibrosis, underlying fibrosis in HP is the single most important determinant for patient's prognosis. So, differentiating only based on CT scan between a fibrotic HP from an IPF is very critical and, however, very difficult as well. Now, coming to the role of bronchoalveolar lavage. So, is BAL actually necessary? So, ATS says that yes, you should do a BAL. However, the Chest Society guidelines, they say that based on inciting antigen, based on the HRCT, and you can do a MDD and then you can diagnose confidently. However, the ATS says that you should do a bronchoalveolar. So, is BAL always necessary? So, it is useful when the pre-test probability is high, but discordance exists between history and imaging. So it means that when the BAL is useful, when there is a mismatch between the clinical history and imaging. So a finding of more than 30% lymphocytes increases the confidence in highly probable HP diagnosis. So you do a BAL when there is a mismatch between the clinical history and imaging. And if you find more than 30% lymphocytes in the lavage, so it significantly increases our confidence that it's a highly probable HP diagnosis, and it may help us to avoid an invasive biopsy. So while the absence of lymphocytosis lowers the probability in non-fibrotic cases, it does not exclude fibrotic HP. So if there is uh, less than 30%, so it lowers the probability of a in non-fibrotic. However, it cannot exclude fibrotic ILD, HP. So in fibrotic HP, more than 30% is highly specific. However, absence does not exclude HP. So you may still need a biopsy. So, however, in non-fibrotic ILD, non-fibrotic HP, absence of lymphocyte, that is less than 30% lymphocyte, significantly lowers the probability and generally excludes HP. Now coming to the histopathological comparison. So BAL is most useful when there is a mismatch, as we have talked. Now we talk about the histopathology comparison matrix. So pathologically, we distinguish between non-fibrotic and fibrotic patterns. So in non-fibrotic HP, it has four major features. Typically, small airway involvement, uniform cellular interstitial inflammation, cellular bronchiolitis or cellular NSIP, predominantly lymphocytic infiltrate, and poorly formed granulomas and or multinucleated giant cells. So in non-fibrotic HP histopathology, you will find four main features: small airway involvement, uniform cellular interstitial inflammation, that is cellular bronchiolitis, cellular NSIP. You will find predominantly lymphocytic infiltrates and poorly formed granulomas and or multinucleated giant cells. As in fibrotic HP, there are three main features you will see. One is airway-centered fibrosis with or without peribronchiolar metaplasia. So generally, you will find fibrosis which is centered around the airways, and peribronchial metaplasia can be there or cannot be. Both it can be present and can be absent also. Then fibrosing interstitial pneumonia can be UIP or fibrotic NSIP patterns, and poorly formed granulomas. So again, there is a diagnostic flexibility in this. So granulomas may be absent in both forms, and it can still be compatible with HP. So in these cases, we should evaluate for chronic aspiration, which mimics fibrotic HP histology. Now the unified diagnostic algorithm, ATS and CHESS both say this. So first we have to identify the antigen. So it can be you've identified the antigen, it's indeterminate or it is an unidentified antigen. So then you do an HRCT, in which it can either be a typical HRCT pattern, that is a 3 density sign, or a compatible HRCT pattern. So then ATS says you do a bronchoscopy. If there is more than 30% lymphocytes, you do a MDD, and after that you reach a diagnosis of HP, or they can have a high confidence of HP. However, if you don't, still after this, you haven't reached a high diagnosis of high confidence of HP, you can either consider surgical lung biopsy or a transbronchial cryo lung biopsy. So, TBSC is preferred because it has lower morbidity. So again, in a diagnostic algorithm, first identify the antigen. Either you identify the antigen if it's indeterminate or unidentified. Again, you have to do a CT scan. If it is typical CT pattern, 3 density, then you have a very high diagnosis of HP. You can do a BAL with more than 30%, it generally confirms the diagnosis of HP. If there's a compatible HRCT pattern, if the BAL is more than 30%, then diagnosis of HP is there. But if still not more than 30%, you have to do a multidisciplinary discussion and you can have a high confidence afterwards. So now coming to the prognostic risk. So when you're assessing the mortality risk, so you have to look at several threat indicators. So it is divided into intrinsic and exposure, radiology, physiology, histology, and bar. So each of these has a different risk factors which are present, which make the prognosis of HP poorer. So if the person is of male gender, elderly, smoking, you're not unable to identify the antigen, or you're unable to remove the inciting antigen. So the prognosis becomes poorer. Again, in radiology, if the fibrosis is present and the fibrosis is extensive, if there is honeycombing present, if there is traction bronchiectasis, or if there is a UIP pattern, then the prognosis is poorer. If there is air trapping or mosaic attenuation present, it predicts a better survival. On PFT, if there is a low FVC, if there is a low DSCO, and there is a rapid decline in FVC, then it has a poorer prognosis. And on histology and BAL, if it's a UIP pattern, if it's a fibrotic NSIP, if there's deposition of dense collagen and there are low BAL lymphocytosis, so it has a poorer prognosis. So again, elderly male, smoker, if you're not able to identify the antigen, if you are unable to remove the antigen, and on radiology, if there is fibrosis and it is extensive, there is presence of honeycombing, there is presence of traction bronchiectasis, if it's UIP pattern. On spirometry, if there's a low FVC, low DLCO, and a rapidly declining FVC. And on histology and lavage, if it's a UIP pattern, fibrotic NSIP, dense collagen on histology, and lower bowel lymphocytosis, so all is a marker for a poor prognosis and progressive fibrotic phenotype. So now talking about the progressive fibrotic phenotype. So for patient whose fibrosis worsens despite management, it is worsening fibrosis on HRCT. There's a decline in FVC and which has early mortality in these patients. It clinically mirrors IPF. So in these cases, you have to give an nintedanib. So there's an inbuilt trial, you can read it on the net. So nintedanib is an intracellular tyrosine kinase inhibitor. And in the inbuilt trial, they found out that it slows the decline of FVC by 57% over 52 weeks. And it reduces the risk of acute exacerbation or death. So in the inbuilt trial, nintedanib, mainly for IPF it was, but it is progressive HV is similar, clinically mirrors IPF only. So it slows the FVC decline by 57% and reduces the risk of acute exacerbation or death. Now, pirfenidone. So there have been open label and retrospective studies. So there has been a relief trial which you can study. So it shows a smaller decline in FVC, but however, there are no randomized double-blind consensus as of now for pirfenidone. So how do you manage HP? So phenotype-based pharmacological management is now the gold standard. So again, first and the foremost crucial step is antigen avoidance. So if you have been able to identify the inciting antigen, you have to avoid it at all costs. This is crucial for both fibrotic and non-fibrotic HP. In non-fibrotic HP, it is generally if the patient is stable, you just observe. And if the non-fibrotic HP, it is severe or there is progressive non-fibrotic HP, or you need some symptom control, you can consider corticosteroids. However, there is no proven long-term benefit. So non-fibrotic HP, if the patient is stable, you just have to observe. If it is a severe or a progressive non-fibrotic HP, or you need good symptom control, patient is very symptomatic, you need good control, then you can consider corticosteroids. However, there is no proven long-term benefit. Now coming to fibrotic HP. So fibrotic HP, you have to consider immunosuppressants, MF, azathioprine. Evidence is limited. So there was a Panther trial in IPF which raised concern over chronic immunosuppression. And if the disease is progressive, you have to add antifibrotics, nintedanib. So in fibrotic HP, you have to consider immunosuppressants, mycophenolate mofetil MMF as a thioprin, and if you have to add antifibrotics if the disease is progressive in nature. Another side note, rituximab may be considered for refractory HP, but the studies are very limited and very small. So first again, telling the treatment again. So first and foremost is if you have been able to identify the inciting antigen, you have to avoid that antigen at all costs. Then in non-fibrotic FG, you just have to observe the patient if the patient is stable. However, you can consider adding corticosteroid if the disease is severe progressive. Now, in fibrotic HP, you have to consider immunosuppressant, mycophenolate mofetil azathioprine, and you might add antifibrotic, that is nintedanib, if the disease is progressive. And in these cases, you can consider rituximab if the HP is refractory HP. However, the studies on rituximab are very small and less. So that's it from my side. Thank you so much.
Thank you very much for the very good that any kind of doubt. Thank you very much. Great.
Thank you, Dr. Rajan, for the wonderful talk. If there are any queries, please feel free to ask. Yes, the presentation will be uploaded on our YouTube channel. So I think there are no questions. So thank you, Dr. Rajan.
Thank you so much.